my disclosures again. So this something that happened in the middle of the night. I was sleeping in my bed, dreaming, and immediately I received a phone call by the hospital. And this was, the vascular surgeon from the emergency department. He asked me, "Hello, doctor, are you the interventional radiology on call tonight?" I said, "Yes, I am." "Oh, excellent. We need your help." I said, "Excellent. It's 3 o'clock in the morning, what is going on?" We have a 72-year-old male patient who came in for an acute ischemia on the right leg. We tried to do an embolectomy, but we were unable to advance a Fogarty catheter down to the popliteal region, and we removed just few fragments of the flesh thrombus. Okay, but does the patient suffer any trauma or any other disease that can justify this situation? He said, "No, we did just a Doppler ultrasound, and the strange thing was the presence of an homogeneous mass in the distal portion of the leg, around the muscles. But there were no flow in the distal SFA, very poor flow in the popliteal region." Okay, but how the patient now is doing? Not very well. He is suffering for pain in the right foot. The foot is cold, and there are some signs of a critical limb ischemia. Okay, we can exclude an aneurysm because obviously this is, the first thing that you start to thought also in the middle of the night. He said, "Yes, but I'm not sure." Okay, so I come to the hospital, but in the meantime, let's do a CT angio just to be sure that there is nothing at that level that seems to be pretty strange. So just to recap, this is the medical history of this patient. Is a diabetic with hypercholesterolemia, and also, nothing special, not smoking, nothing else. From a clinical point of view, he came to the hospital, but the pain started 4 days before, with also some tense swelling, and there was a coolness on the right foot, and there are some sign of critical ischemia. He reported no history of trauma, no disease in the peripheral vessels, and obviously no aneurysms. From a clinical point of view, there was also a reduction of the HB level. When he came to the emergency room, this was 11, and then after 6 hours after the operation, dropped down to 9.8. Again, the color Doppler showed this non-homogeneous mass at the level of the tight muscle and the distal portion of the leg. So finally, we had the CT, and these are the images. I don't know if some of you would like to comment or say something about these images, but you can see that is obviously the right leg was a little bit, bigger than the contralateral one, and no flow in the distal portion of the SFA, and also on the MIP reconstruction. The only thing was pretty strange, the presence of some calcification, I think, in this area. According to the report from the guys from the CT, they told us there is obviously an hematoma around the distal portion of the SFA. The SFA in the distal portion is completely occluded. There is a tissue swelling. The popliteal artery is patent. Obviously, there is no aneurysm, but the distal runoff is pretty poor. So we bring the patient, into the, this is what they did, in the surgical operation before, embolectomy, and using a Fogarty catheter. And remember that he told me that they was unable to advance the catheter in the distal portion, and just fresh thrombus material was removed. So we bring the patient into the cath lab. We did a contralateral access, because on the right side there was the surgical access. We use a crossover technique with a 4 French introducer plus a 4 French rim catheter to perform easily the crossover, and it was the initial angiography. You can see there is just, the evidence of the SFA and then some collaterals in that area, and this is the distal portion of the SFA. You can see there is no more flow in the, in the popliteal region. This is more or less the level of the knee, and there is also obviously an extravasation of contrast media at that level. So the question is now, what happened in this vessel. Because the first, we were a little bit afraid that maybe the surgeons moving the catheter in a blinding fashion and with some difficulties can make a iatrogenic rupture, iatrogenic lesion in this area. So he asked me why you can try to do something. Obviously, as we are, we are working, we try always to put the guide wire to any kind of lesion. So I went down with a 035 standard angle hydrophilic guide wire to get a 4 French vertebral catheter. But you can see that the guide wire was completely outside the vessel. This was my feeling, and there was no way to go distally in that region. And you can see also that after the injection, there was a pretty large also extravasation and some hematoma. So obviously now the discussion was how to manage this situation. Obviously there were 3 options in our opinion: surgery, endovascular, or the most common sometimes in middle in the night is wait and see. We discussed together with the surgeons the different options. I don't know if maybe someone of the panelists have some idea how to manage this situation. No ideas? No ideas. So for me, basically was to send the patient back to surgery, because obviously this was clearly a damage of the SFA with a complete interruption of the connection between the proximal or medial portion of the SFA and the P1 segment. And definitely is something that maybe works not well for endovascular, but also wait and see looks not like the most easy way to manage. So I went outside the cath lab, I started to talk with my surgeons, but honestly, my feeling was that the only option that the surgeons has for this patient was something that, in my opinion, was not very good. Just to do some very invasive procedure. Reason why I decided, okay, let's start to think about a plan B. So what we can do in an endovascular fashion. Definitely this is not an easy situation, also because we must be very lucky to create again the connection between the 2 stumps of the vessel. So my idea was to go from a retrograde approach from the popliteal artery, try to perform a rendezvous technique and restore the communication between the 2 stumps of the vessel, and then to deploy a stent graft. This is, how we enter the popliteal artery with a patient in a supine position according to our standard fashion. We were lucky to get in, and after that I advanced the guide wire in this area that is completely outside the vessel, because we enter in the distal portion, but in the in the more proximal one there was obviously no way to re-enter the SFA. We tried several times also to re-enter the catheter, no way, so we decided to use a 30mm gooseneck from above, and using this we were able to snare the guide wire that we inserted from the popliteal approach and to restore the continuation of the SFA in that region. So at that point, we advanced a catheter from the femoral approach, and we did it in injury. You can see we have a quite good popliteal vessel. We have 3 vessels enough, so pretty good at that point. So now, obviously, the only way to manage this situation was to deploy a cover stent graft. We select a Viaband 6mm by 150, and we perform a post-dilatation using a 5mm balloon. And obviously, then we can discuss maybe the indications of a cover stent graft in this situation. This was the final injury. You can see pretty happy. By the way, there was something a little bit strange in my opinion, because generally this looks not like the standard morphology of the distal or P1 segment. But we discussed also with my colleagues, and finally we came to the idea that the vessel was a little bit squeezed by the huge hematoma and the mass that was revealed at that area. So 24 hours, they perform also medial and lateral fasciotomies just to reduce the pain and to increase the flow in that level. The post-procedure period was uneventful. 10 days after the procedure, they closed the fasciotomies were closed, and a couple of days later, patient was discharged and sent back home in good clinical conditions. After 30 days, we performed a core Doppler ultrasound that showed the complete patency of the SFA with very good flow distally, and patient was completely asymptomatic. This was the Doppler ultrasound, triphasic flow in the pulpiteal region, happy about this outcome. 6 months later, patient came back to the hospital again with the same symptoms, with a right thigh pain, swelling, fever, and a skin ulceration. We immediately performed an evaluation of the laboratory evaluation of the blood, but there was no evidence of a microbiological, infection. So this seems to be not the reason for those symptoms. This was the skin at the level of the knee, more or less in the pulpiteal region, and what you can see in the black portion was a portion of the stent graft. So we did the CT angio. You can see that what we observed at the beginning, it was the strange, also shape was also not more evident, so that was correlated to the hematoma. But you can see how this changed completely the morphology and the position of the stent graft. You can see on the axial image that is very near, to the a sort of fistulization with the skin, and so we have this ulceration. What to do? Obviously, surgical operation. They remove the stent graft. They perform a fem-pop bypass using a reverse venous vein. There was the SFA was ligated in the proximal region, and then obviously now we have a positive microbiological culture for the microorganisms. The inflammatory parameters were normalized after 2 weeks under medical therapy with antibiotics. 20 days after the patient was discharged, and after 1 year the follow-up was pretty good with patency of the bypass, but unfortunately we missed the patient after that because he went to Africa to finalize his job. So this is one of the most, complicated management of the patient, and thank you for your attention.